Thank you. I wanted to thank the organizers for inviting me, especially my friend Pablo Rojo from the 12 de Octubre in Madrid, close to where I work. And he asked me, or they asked me to talk about epidemiology and some clinical presentation of group streptococcal infections in children, especially because of this outbreak that we are having all over the place, it seems to. So just to start, we know that the group Streptococcus is one of the most common microorganisms causing infection in children and adolescents. So there are more than 600 millions of group strep cases and more than 700 millions, for example, of pyoderma annually. And among one things and others, pyogenic infections or acute rheumatic fever, there are more than 500,000 deaths a year, especially in low-income countries. As everybody knows, the transmission occurs through respiratory secretions, and this bacteria has been prevalent for centuries, causing a wide range of severe and non-severe infections, as well as non-suppurative complications. And it's very common also its role in common syndromes like acute tonsillitis and erysipelas. So here, there's some very classic infections like the acute tonsillitis in children, especially from 5 to 15 years old, scarlet fever with the typical sandpaper rash and the erythema in the cheeks, or these erysipelas, which is a superficial cellulitis. So Streptococcus pyogenes, or group Streptococcus, is a gram-positive coccus, aerobic, normally grows in chains, as you can see here. And it has more than 20 serogroups, but these serogroups, which are carbohydrates of the cell wall antigens, they are not immunogenic. The real immunogenic are the serotypes, and the next speaker is going to talk about that. But just to say a few things of the pathogenesis, the M protein, which is, it tells us what is going to be the serotype, is a major virulence factors. And mostly this bacteria produces infections in humans. So why is important the invasive or group Streptococcus infection in children? First, because it has a great importance in pediatrics. One of the things is it causes infections in healthy children. One of the reasons is because it somehow overpass the innate immunity. So it can go to the innate immunity and goes into the body. And I have one slide about that. It has a high morbidity and mortality. Thank God in our zones or in our settings, the mortality is not very high, but the morbidity is very high. And it seems that the incidence may be increasing, not just for the past few months, but even before, as I showed you in a minute. So there are three main mechanisms of virulence of this bacteria: suppuration and inflammation, and it produces empyema. We know how pyogenic this bacteria is. It can produce toxins, which causes scarlet fever, toxic shock syndrome, or necrotizing fasciitis, or immune-mediated inflammation. So not only acute infection, but also future infections produced by autoimmunity with acute rheumatic fever or glomerulonephritis. So what it does, this bacteria first colonizes the upper respiratory epithelium or the skin. It produces like a biofilm. I'm not going to go into this, but just to have a background, that it goes into the cell and then finally invades the tissue of the organism. So there are different toxins, different proteins who favor their virulence, and there are a lot, but I have marked here the protein M is one of the most important, and I'm not going to go into that, but some of them, you know, these toxin likes the streptolysin that can make pores in the cells and kill leukocytes, for example, or activate inflammasome and produce a lot of inflammation. So this bacteria has a lot of different factors to create the perfect environment to invade and to disseminate within healthy people. And also, it seems that there is some susceptibility by the host. For example, we know that after during the pandemic, we have been isolated or microbiologically isolated. So probably we don't have as many antibodies against the M protein, against the superantigens. These antibodies or antibodies who protects us from this infection. There has been also some HLA haplotypes or polymorphism that may favor the several invasive infection by this bacteria or rheumatic cardiopathy. And this is a very interesting field being studied by different groups. And also some immunological characteristics, for example, is being clear, or it seems that for this bacteria increases the levels of IL-1 driven inflammation without being the inflammasome in the middle. So there are different things that the host can have to make more susceptible to this infection. As we know, there's a great variety of clinical syndromes, and here is summarized more or less what this bacteria produces. It can produce non-invasive moderate infection, acute tonsillitis, as we said before, impetigo, cellulitis, erysipelas. It can produce these non-suppurative complications. Scarlet fever is one of them because of one toxin, or rheumatic fever, or one of the most scary, which are the invasive infection. These infections are any infection produced by group A strep where you isolate the bacteria for a normally sterile place. It can be blood, it can be CSF, it can be pleural fluid, synovial fluid, etc. These are a list of different clinical syndromes that this bacteria can produce, and as you can see, it's a lot of them. Pneumonia is very important, very severe, just primary bacteremia, some ENT infections, meningitis, osteoarticular infections is very common, cellulitis, as we said, necrotizing fasciitis, or toxic shock syndrome. So in the next slides, we're going to talk about the increased incidence of this infection, of this disease. So everything came from this alert from the UK, because in England and in Wales, scarlet fever and invasive group A strep disease or infection is surveilled, or there's a surveillance system. So they came up with an alert because they saw an important increase in November and December of cases, both of scarlet fever and invasive infection. So just as a background of the invasive and the incidence of this infection, as we said, the mortality declined in the 1800s till the mid-20s and became very rare for many years. In the 1980s, it seemed that different, more virulent cases started to be reported in the US, in the Europe, and increased the incidence 3 to 8-fold. Just to have an idea, in developed countries, the incidence is between 1.5 to 3,500,000 persons per year, whereas in the low-income countries is much higher, between 12 and 83 per 100,000 persons per year. So this is from the 2014 for the Eurosurveillance, and you can see in blue bars is from 1975 to 1993, in the second period from 1994 to 1212, the red bars. And you can see that the ages usually most common affected are young children under 10 years and the elderly are above 60 years and beyond. But you can see that the incidence was higher in the second period. The same was in this study from 2015, where the incidence of the invasive group A Streptococcus disease in New Zealand was increasing from 202 to 12. This is a very classical study from Finland, where published in 2016. And again, you can see that the invasive group A strep infections were going up from 1996 to 2010. So it seems that not just now, but also within the past 10, 20 years, the incidence of this severe infection is being increasing. This is a Spanish study also, and as you can tell, it seems that there is a tendency to increase. And this last study published by our group in the Gregorio Marañón from 2006 to 2012, we measured the incidence in both two ways. Cases per 100,000 emergency per year was almost significantly increased. This is the red bars, and the blue bars were cases per 100,000 persons per year, and also it was significantly increased from 0.9 to 3.6 in the second period. So what happened with this outbreak in the UK? So the notification of scarlet fever in England were higher than normal for this point of season, and also of invasive disease. Here is scarlet fever, and you can see the tremendous increase of scarlet fever reported by physicians in UK from week 41 to week 3 or 4. Now it seems to be going down, although they are saying that we have to be cautious because there may be a delay in reporting. And the same here with invasive group A strep infection. It went very much higher than before, and it seems that going down, but we have to be careful. For one of the reasons is usually we are in the middle of the season, so we don't know if we are going to continue having an increase after that. And what is going on now is that it's a delay in reporting. So here is by age. You can see that a tremendous increase. These are the previous years. This is from 2017 to 2019, the blue line, and 2020 to 2022, the orange line, and this gray line is from week 37 to week 2, which is the last reported by UK, or at least that I've seen. And I wanted to show you, first of all, how many, the group of 1 to 4 years is very affected by this. And see, like 6 weeks ago, you can notice the tremendous increase that's been this past 4 or 5 weeks. Now it seems to be going down, but see how much higher the incidence is being in just in a few weeks. And you can here the percentage of children involved was 21% compared to 5 to 13% that's been in the past 5 seasons. And I just wanted to show you that the resistance went down. This is probably because, I guess, of the pandemic. I'm not really sure, but it went down from 10 to 4% for clindamycin and 20 to 4% for erythromycin. In our network, the resistance to clindamycin and erythromycin is quite low. So we created this national network in 2018. We didn't know that this was going to happen, but we thought it was very important. This infection is not a non-notifiable disease. You don't have to report this in Spain. So we created this registry by the Red Cap platform that many people use, and we just reported invasive group A strep infection, so toxic shock syndrome. We sent an abstract to our national conference in November 30th, and we have only 106 cases. And I wanted to show you that just 1 month and a half later, or more or less, we sent another abstract to ESPID, and we have doubled the number of cases because we also warned the doctors. We started to work harder in collecting data, and actually we were financed to do a pilot study that is ongoing to do a gene sequencing of host response with case controls. But I'm not going to show you data so now. Right now we have 3 of 6 cases introduced in 24 hospitals, but I'm gonna show you some data of not all of the 300, but 260 that which is being analyzed so far. So here is a publication that just came out in the Lancet Regional Health, and you can see the red lines are remarkable changes in public health measures to prevent COVID. So here, and here is where we use masks and we were more isolated. And the blue shadows is the RSV epidemics. And you can see how the invasive group went from 2019, 2021, almost disappeared during the pandemic, and now increased, but not only increased in 2 months, increased tremendously, similar to what happened in England. And this is data from 295, which is similar. The only thing is that we are probably seeing also a decrease in incidence now. These arrows are showing just the different Januaries of different years. This is pre-pandemic, but compare pre-pandemic to post-pandemic, the difference in incidence so important in the number of cases in this case. I just wanted to show you what happened with the flu and the RSV in our country. So during these months that there was a tremendous increase in group A strep, see the flu and see the RSV, so we can make our own conclusion. But one of the things is maybe, and that's why we have so many pneumonias, the flu and the RSV together, which have been very virulent, maybe they have something to do with this increase of severity and incidence of group A strep. There has been other reports in France, in Denmark that an increase in Denmark almost triple, and the United Kingdom, as I said, probably is decreasing since December, although they, as I said before, you have to be cautious, but maybe the reporting is delayed. Okay, so I don't know how much time I have, if 5 or 10 minutes, but I wanted to talk a little bit about clinical syndromes. If somebody can tell me, I might like to have 10 more minutes, but I don't know if I have. So this is five. Okay, let's say 7. So this is our studies in the hospital. You can see, just wanted to show these are the different clinical syndromes, but look how many pneumonias. Is not very high compared to what I'm going to show you in a minute. And this is the same. It was a 14% of this another study that we did in Madrid from 2006 to 2015. So 14% were pneumonias. So it's been reported also that in England, the pneumonia increased about 28% in November compared to before, and that many of them had co-infection also with virus, although this seems similar to what happened before. But look at here, the isolates from pleural fluid went from 2018 to 2022 compared to 2022 to 23 went up very sharply. And here the same, you can see the pneumonias were much higher here than in the other periods of time. How about the mortality? So the mortality in England, it was approximately in children 7%, and it lasted until the beginning of January. It's been 7.1 to 7.8%. But as you can tell, whereas the death of adults has increased from 61 deaths to 11, which is the total, from children it went from 14 to 30. So it seems that somehow the mortality has stopped. I don't know if we have learned something about that, if we are treating more with antibiotics or what, but it seems that the mortality is going down. And in the last week, there hasn't been any deaths. This is another report from the Netherlands, but I think I'm gonna pass it because it doesn't. It's from children from 0 to 5, and it tells the same that there has been an important increase. And look at here, the mortality is about 21%. The only thing from this study is that they already saw an increase before. So in the first half of 2022, they saw an increase of necrotizing fasciitis, whereas in the second part, it was more toxic shock. And you can see in this graph how during the whole year, there was already an increase from the beginning of the year, not just at the end of the year. So this, the epidemiology group has said is very clear that it's going up, but it's not very clear how is it behaving in every zone, in every area. This is from our study. As I said, 260 cases, 57.9% were male. The median age was 15. Initial treatment with clindamycin was 41%. The resistance was low. Surgical intervention 43. And I would like to remark this: 41% of the children were admitted to the PICU. The sequelae was 7.4%, and the mortality around 2%. Compared to this study just published also, although they are children for 2012 to 2016 from the Euclides network in Europe, so the age is similar, the percentage of male also, the PICU admission is also very high, and sequelae and mortality is very similar. Whereas before, the PICU admission went from 18 to 33%. So these are our clinical syndromes. First one, pneumonia, very clear, ENT infections, skin infections. You can see, I can show you here also that there were 46 cases of sepsis, including 25 cases of toxic shock, and 25 of the cases were multifocal infection. We have pyomyositis, we have foramen meningitis, we have orbital cellulitis, very severe infections. And I like this table. As I said, the PICU admission 141%. You can see in green are the clinical syndromes that are less admitted to the ICU, whereas these three last ones tend to be more admitted to the PICU, and there is a statistically significant. This is the last slide, I think. So it's in Spanish, the title, but it means the risk factors to be admitted in the ICU. there was an increase in the cyclical period, 46% compared to 2019, to the pre-pandemic time. Children were younger, they had less trauma, so children not admitted in the ICU, 45% had trauma, whereas in the PICU, 9%. Osteomyelitis, septic arthritis, they were not admitted to the PICU. They had more respiratory infections in the last month, acute influenza infection, and I want to show you, this is very important for me. Prior antibiotics somehow protected of being admitted to the ICU, and you can see there the rest like inflammatory parameters. And when we did a multivariate analysis, the period still was significant, clindamycin use was significant. We can talk about that, not really sure if it's a cause or a consequence, and influenza was very significant. So just to conclude, there has been an important increase in the incident rate of invasive group A strep infection in both children and adults after the COVID pandemic, possible multiple causes. I'm not going to start talk about serotypes, but it might be respiratory infections, it might be the loss of immunity. There's an important increase in pneumonia and other severe syndromes, an increase in PICU admission, and not as much in mortality in these children. And there's an important warning for the general population and for the health provider. You have to be cautious in children who get very sick after an upper respiratory infection, rapid treatment of non-infectious group A strep infection, and vaccination, especially flu vaccine and varicella. And basic maintain of an active surveillance of invasive group A strep. I would like that Spain finally move forward and create a surveillance for this severe infection. Thank you very much.
Thank you very much, Maggie, for that kind introduction. Indeed, I wanted to disclose that I'm a co-inventor on a licensed patent for a group A strep vaccine. And I also receive fee-for-service and consultancy fees from two pharmaceutical industries, which are directly paid to the institution, but they are related to different topics than we talk about today. So just a recap, a little bit, of course, of what we have already heard from Jesús, but strep pyogenes is actually one of the top 10 most lethal pathogens globally. So the 700 million infections that it causes on an annual basis, most of them, fortunately, are superficial and self-limiting, such as the pharyngitis and the scarlet fever that you have heard of. But the problem is in the invasive infections, which is a whole range of different clinical syndromes, and especially in the low and middle income countries or the indigenous populations, group A strep can result in post-infectious immune sequelae, such as rheumatic heart disease and chronic renal failure. And this is actually quite a big burden of disease for these countries. And this contributes largely to the estimated 500,000 deaths that occur annually worldwide. Unfortunately, we do not have any vaccines available to reduce this global disease burden, and it's actually quite a challenge to develop such a vaccine. One of the reasons being that if you induce the wrong immune response, then you could end up giving your vaccinees an autoimmune disease. So to track the epidemiology and disease burden of this pathogen, we have different tools available. One of these you have already heard through Jesús, which is the statutory notifications, which can be restricted to certain clinical pictures, but always involve a positive culture. These statutory notifications are country dependent, as we have heard. So England has a certain list of disease manifestations that are notifiable. Other countries do not have such a statutory notification in place. But the main aim of such statutory notification is that you can actually intervene in the spread of these very severe infections by either giving chemoprophylaxis to close contacts of the index patients, or, for example, in the case of puerperal sepsis fever, there may be a common source, such as the midwife or the OB/GYN doctor, that spreads the disease between newborn mothers. So that is why you want to be able to track these types of infections. But this is just, as you have heard, the tip of the iceberg, because there are much more different clinical invasive disease manifestations that can be caused by this pathogen. So how can you keep track of this whole range of infections? So one way of doing this is actually not look at the disease symptoms, but go with the bug, so bacteriological surveillance. And in this case, you do not have to restrict yourself to a specific clinical presentation, but you go in with the cases that result in a positive culture with strep pyogenies. And this will give us for sure a more complete picture of the incidence and prevalence of these very severe invasive infections by group A strep. So how do we deal with this in the Netherlands? We actually have different data sources available to track the epidemiology of strep pyogenies. First of all, we do have the statutory national notifications, which came into place in 2008, but these are limited to 3 clinical syndromes: necrotizing fasciitis, streptococcal toxic shock syndrome, and puerperal fever sepsis. And as I said, these are related because we can intervene in the spread of these diseases by either giving antibiotic prophylaxis or doing source tracing. And the second tool that we have in place, which actually came about only recently, is the molecular bacteriological surveillance, which also looks at the type of group A strep that causes the disease. And sometimes we also perform whole genome sequencing to gain more insight into relatedness between cases. And the third option I will not discuss today, but is actually also an interesting tool to consider, is that some non-invasive disease manifestations such as scarlet fever and impetigo are tracked through the general practitioners network through specific diagnostic codes. So this graph you have already seen. It's a bit updated for the first part of January, where these are the official notifications for the 3 notifiable clinical syndromes: the necrotizing fasciitis on top, puerperal sepsis fever in the middle, and the toxic shock on the bottom. And indeed, as you had already seen, 2022 saw a big increase actually in all 3 of these syndromes, not only compared to the pandemic years 2020-21, but also compared to the pre-pandemic years from 2016 to 2019. What was especially noticed, and this was already early on in 2022, that there was a big increase in invasive group A strep infections in young children, ages 0 to 5 years old. And this is what is plotted in this graph, where you can see again the time range from 2016 all the way to January 2023. And what is very clear is that 2022 saw a big number of invasive group A strep infections in this age group, 42 in total. 9 of them died, but this could actually well have been an underestimation because the outcome is not notifiable. And what was noticed in this data was that 7 children had reported concurrent or preceding chickenpox, and 2 had a tonsillectomy. So this is just data for the notifiable disease manifestations, but through a convenience consortium of pediatricians, and I was actually also included as we had the isolates, and did from 7 hospitals. They looked at the number of cases between July 21 and June 22 and compared it to the pre-pandemic period. And they found in this period alone from 7 hospitals, 49 invasive group A strep cases in this age group. 9 had preceding or concurrent influenza infection and 16 had chickenpox. So what about the type of group A streptococci that caused this disease? For this, I would first like to give a short introduction on the Netherlands Reference Laboratory for Bacterial Meningitis, just to give you some background on the way this works in the Netherlands. So our reference laboratory actually has a very long-standing history, the start of it, or at least the unofficial start, dating back to 1959, from an initiative of one of the professors, Anna Charlotte Ruys, here in Amsterdam. And she was very interested to look at the epidemiology of meningococci, so Neisseria meningitidis infections. And she asked colleagues around the Netherlands to send her meningococcal isolates from patients with invasive meningococcal disease that she could then type and maybe get a better look at the relatedness between cases. And this was actually so successful that in 1974, this became an official collaboration with the National Institute of Health and the Environment, the RIVM. And it was decided that the surveillance would be extended to track actually all-cause bacterial meningitis. And these are some of the pathogens that are most commonly found with bacterial meningitis and that we have received and typed ever since. Initially, this surveillance was more about molecular epidemiology and tracking outbreaks of bacterial meningitis, but it became even more interesting when different vaccines were introduced in the national immunization programs against several of these pathogens. The hip vaccine in 1993, meningococcal vaccines, and streptococcal or pneumococcal vaccines. And this baseline that we had created already back in the 60s now was a great platform to look at the effectiveness of the introduced vaccines, track vaccine failures, and also advise on maybe changes that needed to be made to the national immunization program. So annually, the reference laboratory for bacterial meningitis receives around 3,000 isolates on average, and we have over 90,000 isolates stored in our freezers since 1959. For strep pyogenes, our history is a little bit less long. It actually initially was only for patients with group A strep meningitis. And from 2019, we started on actually a pilot study at the time for prospective surveillance for invasive group A strep manifestations more generally. So once an isolate is sent to us, we perform actually Sanger sequencing on 180 base pairs of the EMM gene. This was already also mentioned by Jesús. So the EMM gene encodes for M protein, which is these green hairs that you can see in this electron micrograph on the surface of group A streptococci. And it's a very important virulence vector and a large source for variation, because until now, more than 220 different M genotypes and genosubtypes have been recognized. So for our surveillance, as I said, it was more broadly oriented, where we asked initially 9 sentinel laboratories spread out throughout the country to send to us streptococcal isolates if they were cultured from a normally sterile compartment. And in this way, we would capture all clinical manifestations of invasive group A strep disease. From April of last year, we actually asked all medical microbiology laboratories from the Netherlands to send all their cultured isolates to us if they were cultured from a normally sterile compartment. We EMM type all these isolates that we receive. Some are further analyzed by whole genome sequencing to look at actual transmission patterns. And we performed a patient chart review for a subset of patients that I will not discuss today. So what kind of insight did we get from this prospective surveillance? Well, first of all, if you look at the graph, you can clearly see that surveillance has been quite successful. So until 2019, we only received a handful of isolates in case patients had meningitis. But from 2019, this largely increased, first from the 9 sentinel labs, but in 2022, we received over 1,100 isolates that we could type and store and analyze further. In this data set, we found 109 different M subtypes and types among more than 1,600 isolates. So there's actually large diversity. But if you look for dominant M types, they're definitely there. So the 8 M types that are mentioned here together are about 70% of the collection that we have received so far. And until February 22nd of this year, we already have received 424 isolates. So definitely we're receiving quite some isolates and even more than we had expected. So what we could also see from this prospective surveillance data is that there was a shift in the age of the patients that were affected by the invasive infections. So what I plotted here is per age of the patient, I plotted the number of isolates that we received. And what you can see is that in 2019, we actually had a big number of cases coming from patients with puerperal sepsis fever, which is right around this age group, and also quite a little bit more cases in the 60+ age group. But if we now look at the same graph plotted for the 2022 data, you can clearly see this big increase in the number of cases again in the children ages 0 to 5 years old, and also the elderly are much more affected in this year. And what was already mentioned by Jesús is that we already noticed among the children in the first half of 2022 that the incidence was increased. And looking at the types of group A streptococci that caused these disease, what stood out was two M types, which was M4, you can see here in the blue graph, and M12. And especially M4 was kind of interesting to us because, and these data will come later, we had hardly found this M type when we performed colonization studies. So this was in asymptomatic carriers. M4 was hardly ever, was not a big proportion of the isolates that were carried, but we did find it back among the children that developed invasive group A strep infections. So one of the possible explanations that we looked at was whether there was maybe a genetic variation in the M4 lineage that could explain this increased incidence among the children. And there was this very interesting research paper published in 2021 that had identified a hypervirulent clone among the M4 lineage of group A streptococci that had replaced the preceding M4 clone very rapidly. So this new M4 clone, the hypervirulent clone, had certain characteristics. And what we thought is maybe that this hypervirulent M4 clone was the reason for the increased incidence among the children that we had observed. So to actually study this, we collected 62 M4 isolates from our freezers. Actually, 29 of these isolates were from carriage from the 2009-2019 period, 7 isolates from invasive disease from that same period, and then we had from our 2022 period all the strains up to that moment, which was 26, and these were all from invasive disease. And we submitted these for Illumina MySeq sequencing and assembled them through our in-house pipeline. And what we could actually see, so this is a phylogenetic tree plotting the genetic distances between the isolates that we had analyzed. And in this color here, the turquoise and the pinkish color, you can see to what data set they belong. And in blue here, this is the genetic lineage of the hypervirulent strain that was identified in North America. And what you can see is that actually we do find this hypervirulent clone in the Netherlands, already both in carriage and in invasive isolates. We could trace the first detection back to an isolate from 2009, but most of our 2022 isolates actually fell in this new branch down here, which is actually very clonal, especially these last 15 isolates. They are really, really clonal. And we estimated their emergence only 2 years back. So it's a recently developed clone. And we are now looking into the carriage of this strain. Maybe it's simply a reflection of better carriage and transmission. And we are performing some genotype-phenotype studies to look whether maybe some genetic changes that we see in this lineage can explain the increase in invasive disease. All right, so later on in 2022, we had another change in the molecular epidemiology of invasive group A strep infection, and that is reflected in these two graphs here. On the left-hand side, you have the absolute number of group A strep isolates per month. And the different colors indicate the different M types of these strains. And on the right-hand side, it's the same data, but displayed proportionally to the total number of isolates. And what is very clear is that somewhere between November and December, something which we do not exactly know what, but it caused an enormous dominance of the M1 strains in the invasive disease group. You can see that especially the data that we had until January 2023, nearly 80% of all the isolates that we had received were now of the M1 type. And currently still 60% of all our isolates are of the M1 type. So what could maybe one of the explanations for this very strong dominance of this specific M type? Well, it could be maybe this very specific variant of M1, which is called an M1 UK variant. So this variant was first picked up in the UK, where they have indeed this very thorough and long-standing surveillance system. And they first noticed that they had an increased number of these M1 isolates with scarlet fever, which they had a huge outbreak from. And this was later followed by an increase in invasive group A strep infections, which also showed quite a dominance of M1. So what they did is that they whole genome sequenced all these M1 isolates and found actually the evolution of a new lineage, which they called M1 UK. And this lineage is now defined as having the presence of 27 defined single nucleotide polymorphisms, or SNPs. And what they have shown is that this lineage is more virulent than the preceding lineage, which they called M1 global. And likely what is contributing to this increased virulence is a 10-fold increased production of a certain toxin, which is called SPA. And SPA is a superantigen, which means that it actually triggers more than 20% of your T cells in an antigen unspecific manner. And you can imagine that this leads to all types of negative consequences for the patients: inflammation, fever, cytokine storm, and multiple organ failure, which could well contribute to the diseases that we now observe. So what about M1 UK in the Netherlands? Well, we actually have some data on that, also from a retrospective study that we performed that I did not tell you about today. So in this retrospective study, which spanned 10 years from 2009 until 2019, 52 of the isolates were of the M1 type, and only 90% belonged to the M1 UK lineage. Of these 90%, 80% was already found in invasive disease and 20% in carriage. We could date the first detection back to 2016. In 2019, we performed a similar study on the isolates that we had received so far, and at that time, 15% of the received isolates was of the M1 type, and 64% of these M1s were M1 UK. And we now have taken a small sample from 2022 of 32 M1 isolates, and 90% of them now belong to this M1 UK variant. So it seems to have increased a lot. It actually looks like a clonal sweep of this M1 UK variant from the preceding M1 global lineage. So my title promised something about carriage, so that is what I will end with, because of course carriage can precede all these invasive disease manifestations and is very important for transmission. And we actually had some data on M1 and M4 from this carriage study. So this is again this retrospective period 2009-2019, where you can see that in this period, M1 over this entire period was 15% of the colonizing strains. In green here, you can see M4 that I discussed with you, it's about 10%. And if you look at the different time periods in this time frame, you can see that M1 actually decreased in carriage from about 15 to 10%. Interestingly, we just finished another carriage study which ran from September 22 till February 2023. This is not the final data. We have now about 42 strains, but the 27 we have typed so far, you can actually see that the M1 only represents about 10% of the carriage isolates. So the dominance of M1 that we see with invasive disease is certainly not a reflection of carriage, but more likely a reflection of very strong virulence of this specific M type. For M4, the data looks a bit different, as you can see. So where it constituted about 10% in the 2009-2019 period, in this last sampling study, it represents about 1/3 of all the isolates that we have typed. So probably what we have seen in the children, the dominance of M4, is more a reflection of the high carriage and transmission among this age group. And with that, I would like to conclude. So I hope to have at least convinced you that bacteriological surveillance of invasive group A strep infections is very critical to monitor epidemiology, and especially the changes in epidemiology, and also inform changes to public health policy. So I've shown you this new highly clonal M4 lineage that was dominant among invasive group A strep manifestation and carriage in children. We see a dominance of M1, especially this new UK variant, among IGAS cases in general, but it has very low carriage rates. And all this data has resulted in an adjustment of policy such that we have now extended chemoprophylaxis to household contacts, not of just the 3 clinical manifestations that I mentioned in my introduction, but to all household contacts, or to household contacts of all patients with an invasive group A strep infections. Another thing that we have noticed and that I would like to end with is that the dominance of this M1 UK variant may also affect the clinical presentations that we see. And I would like to focus on meningitis, since we are a reference laboratory for bacterial meningitis historically. We looked at the 40 years of data that we have collected so far. And what we have seen is that in 2022, meningitis was actually 4-fold increased compared to the 40 preceding years. So, and in addition to that, what we could see is that among these meningitis cases, again, this M1 was really dominant, with all isolates from May 2022 belonging to the M1 UK variant. So we think that maybe the dominance of this M1 UK variant could also have an effect on the incidence of certain clinical manifestations that we think of as rare, but may now have increased because of the circulating strains. And with that, I would like to thank the many people that have contributed to this work, my research group here in the Netherlands, Translational Microbiology, the reference laboratory, and all the technicians and the bioinformatics postdoc. And there's many other different people that I would like to thank for this work. And thank you for your attention.
The first question is from John Tembo. What is the indication for whole genome sequencing of isolates? How can we target the use of sequencing in resource-limited settings? This is for you, Nina.
Yeah, I think that's a very important question, because although whole genome sequencing has become cheaper, it's certainly not cheap. So we use whole genome sequencing already in cases where there is a suspicion that there could be a case of transmission by the physicians, and then we verified whether the strains are indeed identical or near identical with whole genome sequencing, or in cases where we had a case where a hospital had cases very closely spaced in time, and they all came back with the same M type. So then there was a suspicion that this could maybe have a common source, and then we went back to whole genome sequencing to see if that was indeed the case. But it doesn't give complete guidelines, I guess, for resource limiting settings.
Thank you. The next question is from Laurie Ivaska. It's to both of you, but we'll let Jesus answer this one. Do you think that the recent increase in invasive group A strep incidence is partly caused by less circulation or transmission of group A strep during the pandemic years, or the restrictions that we experienced?
You're on mute.
You're right. This is a question that everybody asks to everybody, to themselves, and what happened with the group A strep and what happened with other bacteria and viruses. Like the flu incidence that we've seen this year for 6 months in a row is very strange. So probably it's a combination of things. This hypervirulent, I was going to ask you, Nina, about this. These hypervirulent strains, what happened? Were they hiding? Maybe there is a dynamic interaction between the host and the bacteria that it was broken with this isolation period. This is one thing probably. The second thing is the RSV and flu got together, and that combined with the low probably prevalence of antibodies against M type and superantigens, it was a burst for this group A strep. Not only for group A strep, we are seeing other increase, but we don't measure that. But we have the feeling, pediatricians, that we have more invasive pneumococcal infection, that we have more staphylococcal invasive infection. So, but group A strep is especially virulent. We are seeing in clinical symptoms that we haven't seen before: toxic shock, pneumonias, very, very severe pneumonias. So probably it's a mix of things. Nina, I'm sure you can complement what I'm saying.
Yes, no, I agree with you. I think it could be a perfect storm situation where maybe there has been some decreased immunity because of reduced circulation, reduced contact with different strains. The fact that SPA, this toxin that is so abundantly produced by this M1 UK variant, this was actually one of the reasons that group A strep invasive disease emerged again in the 80s, when this M1 at that point acquired again the SPA gene, and now it has just upped the production of the SPA toxin. So it could well be connected to that. Perhaps the strains that we are now carrying are less protective of this more virulent strain. The great number of respiratory tract infections that we see. And of course, for us, we do not have in the Netherlands a chickenpox vaccine in the national immunization program. So that probably contributed to the increase in children that we had seen in the early stages of 2022, so right before summer.
This is interesting because in 2022, we didn't see any varicella associated with group A strep. All 4 infections that are reported in our network are from the 2019 and 2020, because now varicella is almost everywhere in the immunity calendar for children. But that, yeah, and I wonder what's going to happen, because if you see the maps, the group A strep infection is higher now. In March and April, it's also high. So it's going down. I don't know what's going to happen. These interactions, if the flu now is going away, seems that it's going away. I don't know. Surveillance is very important. Analyzing, putting together all this data and discussing, I think is basic now after the COVID epidemic. It's something that we haven't experienced before, and we should be very aware of this.
Thank you, Jesús. I have 2 questions for each, one to each of you. So I'll ask them so you have the opportunity to answer. So to you, Nina, we've seen frequently children without ASL production in our settings. Could you comment on that?
So just the abbreviation ASL is anti-streptolysin then, I'm assuming.
That's what I'm also assuming.
Yeah, right? Yeah. I cannot really comment on that. We don't look at it, but I can imagine that it could be important in defense that you actually do make these antibodies, because it's such an important toxin for virulence. So if you lack them, you may be at higher risk to develop these very severe infections. We do not look at it, so I cannot comment for our own situation, but I can definitely imagine that it contributes.
Okay, thank you for that. The last question, Nina did mention that in some cases, chemoprophylaxis is considered for close contacts. Which chemoprophylaxis do you suggest for household contacts? And do you know if there are other countries which also suggest chemoprophylaxis?
Yeah, so the change that we have made is, and it's actually quite a substantial change if you think about being more actually limited with antimicrobial antibiotic use. But the situation was so alarming to us in the Netherlands that we have decided to expand offering chemoprophylaxis from just necrotizing fasciitis, streptococcal toxic shock, and purple sepsis fever to all household contacts of all patients with invasive group A strep disease. So that is indeed a very big change. We discussed at the time when we made the decision whether we should restrict it. I see somewhere like children maybe higher than 65, which are at higher risk. We have discussed that in the group that was included to actually make the decision on this, and we decided for ease of incorporation of this new guideline, we would not restrict it to specific age groups or people with certain conditions, just for to make it more easy and I'm not getting
more practical.
More practical. Thank you. More practical. And I can now not remember what I want to say that we chose. No, I don't want to burn myself on that. I cannot remember what antibiotic, but if you email me, just email me and I will look up what is in our guidelines.
I mean, probably amoxicillin 10 days is what I would recommend.
No, I think we chose for a shorter regimen because we were worried that people would not adhere to the 10-day antibiotic.
Okay. I think the CDC also recommends only for certain groups of high-risk people like beyond 65 and HIV and immunocompromised. But keeping in mind, I mean, this is a very hot topic. Keeping in mind the increase of invasive group strep infection that we are seeing is something that we have to talk and retalk again and see if it's worth it to change our policies. I agree with you. I'm not really sure if I would go to all of them, but it's something important to rethink in the current situation. I agree.
Yeah. So one of the considerations that we had is that maybe one of the considerations was that this M1 UK variant may actually be increasing the risk for secondary infections. And we're currently analyzing all the data that we have received in our reference laboratory to see if we can identify household contacts that both of them or three sometimes actually developed invasive group A strep, go back to the strain, whole genome sequencing, and confirm our suspicion that there is a higher number of secondary infections at the moment.
It's possible, yeah.
And it could be related again to this M1 UK variant. So
I don't think we have seen that very clear in Spain, but again, we are not very vigilant on this. But personally, I don't think we have seen that, but it's something that we have to be very aware.